Hello my dear students. In this video, we will discuss about scalp. We will discuss about the definition of scalp, the extent, the various layers of scalp, nerve supply, arterial supply, venous drainage, lymphatic drainage, and some applied aspect. So coming to the definition of scalp. Scalp is defined as the soft tissue covering the calvaria. Calvaria is the upper part of the skull, and the soft tissue covering this upper part of the skull is called the scalp. Now what is the extent of scalp? This is the view of the skull when seen from in front. This is the view from side, and this is the view from back. So the scalp extends from the supraorbital line anteriorly, and then it passes over the zygomatic arch, and then it merges with the temporal fascia. Posteriorly, it originates from the external occipital protuberance, and on either side it goes via the superior nuchal line. So this is the extent of the scalp. Now let's discuss about the various layers of scalp. The various layers of the scalp can be remembered by simple mnemonic, that is scalp. S-C-A-L-P. Of these, S stands for skin and C for connective tissue, which is the superficial fascia. A stands for aponeurosis, which is also called as Galea Aponeurotica. And L stands for loose areolar tissue, and P stands for periosteum. So let's first discuss about skin. The skin has numerous hair follicles. Along with the hair follicles, there are also various sebaceous glands for the nutrition of the hair follicles. There are also a number of sweat glands. Due to the presence of a large number of hair follicles, the scalp is one of the most common site for the development of sebaceous cyst. After skin, we will discuss about the superficial fascia, which is formed by connective tissue, which has large number of blood vessels. Because of these large number of blood vessels, the scalp bleeds profusely even under minor injuries. In such cases, we can stop the bleeding by directly applying the pressure on these blood vessels and compressing the blood vessels with the underlying bone. So that is one method of stopping bleeding. Also, due to the presence of huge number of blood vessels and copious blood supply, the scalp is very vital, and the injuries of the scalp heal very quickly. Next, we will discuss about the Galea Aponeurotica, or the layer of aponeurosis. Before discussing the aponeurosis, we need to discuss about a muscle called as epicranius. Epicranius has a long extent, and it has occipital and frontal bellies. The occipital belly originates from the lateral 1/3 of the superior nuchal line as well as from the mastoid process. The frontal belly originates from the skin as well as the subcutaneous tissue. Both these bellies are attached together by a layer of aponeurosis called Galea Aponeurotica. This Galea Aponeurotica is not only attached to the frontal and occipital bellies, posteriorly it is even attached to the highest nuchal line and the external occipital protuberance. Anteriorly, it blends with the subcutaneous tissue just above the nose. Alternate contraction of the occipital and frontal belly will move the scalp anteriorly and posteriorly. Isolated contraction of the frontal belly leads to transverse wrinkles on the forehead, as seen when a person is frightened. Next, we discuss about the next layer, which is the loose areolar tissue, or also called as loose subaponeurotic layer. This layer is also known as the dangerous area of scalp. This is because the emissary veins present in this layer, they communicate with the duravenous sinuses. So, whenever there is an infection in this layer, the infection can spread from this layer inside. That is, it can enter into the cranial cavity, causing meningitis. Apart from that, accumulation of the blood in this layer can also happen. In such a case, the blood gravitates downwards and leads to black eye. In newborn, during parturition, sometimes the face of the scalp is deformed because of the interference of the venous drainage, the shape is changed. This is called as caput succedaneum. The next layer we are going to discuss is the pericranium. The pericranium is nothing but the outer layer or periosteum of the skull. This will cover along all the skull bones except at the sutures. At the sutures, the layer of the periosteum is continuous with the end osteal layer of the dura mater, and on the rest of the places it covers the entire bone. Next, we will discuss about the nerve supply. The nerve supply of the scalp is done by 10 nerves. Of these, 5 nerves are in front of the auricle and 5 nerves are behind the ear. Starting from before backwards, they are the supratrochlear nerve, supraorbital nerve, zygomatico-temporal nerve, temporal branch of the facial nerve, and auriculotemporal nerve. These 5 nerves are in front of the ear, and all these nerves are sensory except the temporal branch of facial nerve. So this temporal branch of the facial nerve, it will be supplying the frontalis part of the epicranius muscle, which we have discussed. The 5 nerves behind the auricles are the greater auricular nerve, posterior auricular branch of facial nerve, lesser occipital nerve, greater occipital nerve, and third occipital nerve. The posterior auricular branch of the facial nerve is the only motor nerve here, and the rest are sensory. This posterior auricular branch of facial nerve, it will be supplying the occipital belly of the epicranius muscle. One point to remember here is the operations of the scalp should be done preferably under general anesthesia, because the dermatose of the trigeminal nerves and the cranial nerves, they have a considerable overlap. Therefore, local anesthesia might not be sufficient in these cases. The next thing we discuss is the arterial supply. We have 5 sets of arteries. Of these, 3 are in front of the auricle and 2 are behind the ear. The 3 in front of the auricle are, first you have the supratrochlear artery and supraorbital artery. Both these are branches of ophthalmic artery, which is coming from the internal carotid artery. The third artery coming in front is the superficial temporal artery. This is one of the terminal branch of the external carotid artery. Behind the auricle, we have the posterior auricular artery and occipital artery. Both these arteries are branches of external carotid. So, the superficial temporal, posterior auricular, and occipital, all these 3 are coming from external carotid, and the supratrochlear and supraorbital arteries, these are the branches of the internal carotid. So, we can say the scalp is a site of free anastomosis between the external and internal carotid arteries. Next, we will discuss about the venous drainage. Venous drainage, they correspond with the arteries. That is, you have the supratrochlear, supraorbital, and the superficial temporal vein in front of the auricle, and posterior auricular and occipital vein behind the ear. The supratrochlear and supraorbital, both of these will fuse to form the angular vein. This angular vein will continue obliquely and forms the facial vein. The superficial temporal vein, it enters the parotid gland and then it joins with the maxillary vein to form the retromandibular vein. This retromandibular vein will again divide into anterior division and posterior division. This anterior division, it joins with the facial vein to form the common facial vein. Whereas the posterior division, it joins with the posterior auricular vein and forms the external jugular vein. This external jugular vein, it will again drain into the subclavian vein in the supraclavicular triangle. The occipital vein usually terminates in the suboccipital venous plexus. Apart from this, there are certain veins called as emissary veins and certain veins called as diploic veins. The emissary veins, there are 2 sets of emissary veins, parietal and mastoid. The parietal emissary veins enters through the parietal foramina and communicates with the superior sagittal sinus. So basically, these emissary veins communicate from inside the skull to outside. You have another set of veins called as diploic veins. The diploic veins, they do not traverse the entire skull. Instead, they go inside the two tables of the skull. The skull has two tables and the diploi will end within the two tables of the skull. That is, they do not go from one side to other side. That is the reason, since they are terminating the diploi, they are also called as diploic veins. Next, we discuss about the lymphatic drainage. The anterior part of the scalp, it is drained by the preauricular lymph nodes. And the posterior part of the scalp drains into postauricular and occipital lymph nodes. Let us discuss about certain applied aspects. The scalp is one of the most common sites for the development of sebaceous cysts. The loose subaponeurotic layer is also called as the dangerous layer of scalp. This is because the emissary veins present in this layer, they directly communicate with the dural venous sinuses. Any infection in this layer, this can spread into the brain with the help of these emissary veins. Hence, this layer is also called as the dangerous area of scalp. Apart from this, the blood can also be accumulated in this layer. And because of gravity, the blood comes downwards leading to black eye. Caput succedaneum is a deformation of the scalp in newborns, probably because of the interference of the venous return. Surgeries of the scalp should be done under general anesthesia, not under local anesthesia, as there is considerable overlap between the various nerves here. So, to summarize, we've discussed about the definition of the scalp, which is nothing but the soft tissue covering the calvaria, extending from the supraorbital margin and then along the zygomatic bone till the external occipital protuberance via the superior nuchal lines. The layers of the scalp can be remembered by a simple mnemonic SCALP, that is the skin, which has hair, sweat glands and sebaceous glands, and then you have the subcutaneous tissue, which has large number of blood vessels and hence the scalp bleed profusely. The blood vessels have copious amount of blood supply, giving a strong vitality to the layers of the scalp, and the tissues heal very fast. Next, we have discussed about the Galea Aponeurotica, which connects the frontal and occipital bellies of the epicranius muscle. The frontal belly is supplied by the temporal branch of the facial nerve, and the occipital belly is supplied by the posterior auricular branch of the facial nerve. So, since both these are muscles of facial expression, they are supplied by the facial nerve, which is the nerve of the second arch. Second arch supplies all the muscles of facial expression. Hence, the occipitofrontalis, or also called as epicranius muscle, is also supplied by the facial nerve. And then we've also discussed about the loose subaponeurotic layer, which is also called as the dangerous area of scalp, and accumulation of blood leading to black eye and caput succedaneum in the newborns. And then we have discussed about the nerve supply by the supratrochlear, supraorbital, zygomaticotemporal, temporal branch of facial nerve and auriculotemporal nerve. All these are in front of the auricle, and behind the auricle you have the posterior auricular nerve, lesser occipital, greater occipital and third occipital nerve. So this is the nerve supply. And then we also discussed the blood supply. The arterial supply is by the branches from the internal as well as the external carotid, which are 5 in number, 3 in front and 2 behind. The supratrochleal, supraorbital, superficial temporal in front, posterior auricular and occipital arteries behind. The veins also followed the arteries, that is the supratrochlear, supraorbital and superficial temporal in front and posterior auricular and occipital behind. So the supratemporal and supraoccipital, they join together to form the angular vein, which continues as the facial vein. And then we also discuss some lymphatic drainage, mainly the preauricular lymph node in front of the ear and the postauricular and occipital lymph nodes behind the ear. And then we have discussed some applied aspects. I hope you've enjoyed this session. Thank you very much.